So
Oh.
this meeting is being recorded, and it is my great pleasure to introduce Jacie. So Jacie Volkman, MPHCIC, FAPIC, is the Director of Infection Prevention and Epidemiology at HCA Mission Health in Asheville. She is a faculty member of the Institute for Healthcare Excellence. She owns a consulting company called Safe Patient Surveys. Since 2006, she started her career as an epidemiologist in public health and has worked in hospitals and infection prevention. Infection prevention experience in many realms includes acute care, long-term care, ambulatory care, inpatient rehabilitation hospitals, ambulatory surgery centers, and others. She is certified in infection prevention and control. Since 2008, she is a volunteer board member, Certification Board of Infection Control, and Western North Carolina AIDS Project, WNCAP. Previously, she served on the board of directors for the Association of Professionals in Infection Control and Epidemiology. She's authored numerous publications related to infection prevention and emergency preparedness. She has a Bachelor of Science in Biomedical Science from Texas A&M University, and she also has a Master of Public Health and Epidemiology and Biostatistics from Texas A&M School of Rural Public Health. And beside all these amazing treasured credentials she has and experience, her hobbies and interests include pre-COVID, running, hiking, and coaching Special Olympics basketball and soccer, and toddler wrangling after COVID, and working constantly. So it is my great pleasure to introduce to you today, Jacie Volkman. And Jenny, I'm not sure that all of your announcements got on. Do you need to repeat those, or you want to start with Jacie?
Why don't we start with Jacie? Thank you.
Okay. All right. Okay, Miss Jacie, we're so happy to have you come today.
Thank you so
Welcome.
much, Karen.
Okay.
Thank you. And thank you all for having me. I'm very excited to talk with you today about COVID-19. As Karen mentioned, I am the Director of Infection Prevention for the North Carolina Division of HCA Healthcare. So I am very deeply entwined in the COVID response here in Western North Carolina. I am over the infection prevention department for all of the hospitals within our division. So that covers about 18 counties in Western North Carolina. And I'm going to talk to you today about COVID-19. So I'm going to start sharing my screen. And just really quickly, a time check. So this goes until 12:30, correct? Karen, Jenny? Karen, I can't hear you.
I think it goes till 1.
Till 1 o'clock? Okay. I just wanted to make sure I didn't go over too far because I do have 97 slides. And
awesome.
I'm going to have to go through them a little bit quickly. But let me get my screen shared. Sorry, my mouse is not cooperating. Okay, here we go. There we are. Okay, can you see my slides?
Looks great.
Perfect. A little bit about what we're going to talk about today. So I'm an epidemiologist, which means I love data, I love graphs, and I'm going to try not to kill you with bar graphs here, but there is going to be a lot of data throughout this presentation because I really do feel like the data that we are seeing with COVID-19 is telling a story. So I'm going to use that data to tell a little bit of a story about what we have seen over the last year and what may be upcoming for us. Before I start with that though, I do want to take a moment to thank healthcare workers for the tireless effort that they have put forth over the last year. I think it's hard for many of us to really understand the difficulty that healthcare workers have faced in this pandemic. Not only is it incredibly difficult to work all day in a ton of PPE, but you're also working in the face of something that's really scary. And healthcare workers have come to work every day. They put themselves at risk, and they've done it to keep all of us safe. And so I really, those on the front line, I can't say enough about what true heroes they are. And to go and see them every day, you know, putting on a strong face and going in and taking really great care of their patients is really something special to see. So here in Western North Carolina, we are truly blessed to have such a great healthcare system where these healthcare workers are willing to go in and put forth that effort for all of us. And then I also want to, is this, there, okay. I also want to talk about a little bit before we start, the true devastation that the nation has felt over the last year. And, you know, because so many of my slides and so much of what I talk about are statistics, I just want to start out by saying that this is more than statistics. This is about human lives. This is about our loved ones. I truly don't know anyone who doesn't know someone or have a loved one who hasn't been affected. And so many of us have loved ones or know someone with loved ones who have passed away from coronavirus. So in the United States, having had over 500,000 deaths, that's not just a statistic. Those are our loved ones. Those are our family members. And so as I go through this presentation, I will talk a lot about statistics, but I did want to start off by saying our loved ones are not just statistics, and that my heart goes out to every single one of you who have lost someone or know someone who's lost someone. And we've not been able to grieve in the ways that we would normally grieve for those who have passed, and that's just made it even harder. And so, you know, before I started, I just want to thank everyone who has come to this to hear the information, and know, please know that my heart is with all of you who have suffered so much over the last year. So thank you for allowing me to talk to you about this really important topic, which is coronavirus. So many of you know all of this information that I'm going to start off with, but for those of you who don't, I will just give a brief overview of what coronavirus is. So coronavirus is a family of viruses, just like there's a family of influenza viruses, and you know, we see a different one that comes along every year, or we hear about the swine flu or the bird flu. Coronavirus is similar to that. It's a whole different family, but it has different viruses within it, and COVID-19 is one of those within the family of coronaviruses. So they're called coronaviruses because of the spike proteins that are on the outside of the virus that you can see here in this picture that kind of look like a crown. So corona is a word for crown. And it is in the same family as MERS or SARS that we have seen in previous epidemics. As everyone knows at this point, the virus did begin in China, in Wuhan, China, in 2019. And what they think happened was that the host, the intermediate host, was a pangolin. So let me go back a slide. So this little anteater aardvark looking thing at the bottom is a pangolin. And what a pangolin is an intermediate host for this virus. So you have a reservoir, which is in this case a bat, and then you have an intermediate host that is likely bitten by the bat that is infected with the virus, and then humans have contact with that intermediate host, and then they get infected. So with MERS, which is Middle Eastern Respiratory Virus, the intermediate host was the camel. And in the Middle East, humans have very close relationships with their camels. They have very constant contact with them. And so that intermediate host was able to pass that virus on to humans, and then humans passed it on to other humans. With SARS, it was the civet cat. So for some of these, like the civet cat and the pangolin, they are sold in the wild meat markets within China. And so that ends up being, consumption ends up being how that host is able to pass it on to humans. So that's a little bit about how the infection goes from the reservoir into the human population. And I know there's been some controversy lately that the former CDC director came out and said that he thought that there was still a possibility that the virus originated in a lab in China. The WHO has come out with a white paper that indicates that they really don't think that that is likely, that they truly believe that this was something that came from bats into an intermediate host into the human population. And everybody knows, I think at this point, what COVID-19 causes. It causes an illness very similar to the flu, where you have fever, cough, fatigue. One of the really interesting symptoms that is caused by COVID-19 is anosmia, which is where you lose your sense of taste and smell. And that has been a really nice side effect for epidemiologists, because it's an easy way to determine that this is not a common cold or influenza, because the loss of taste and smell isn't a symptom that we would typically see with other respiratory viruses. So it helps us a little bit. If somebody presents with that, then we're pretty sure that that's what they have, even without them having been tested. I'm going to talk a little bit about how deadly COVID-19 is. So this data is a little bit funny for a couple of reasons. Number one, this is data that's a little bit old, and so it hadn't been updated for me to show you more updated data, but you can adjust it in your mind a little bit. So COVID-19, when I took this first snapshot, was only at 116,000 deaths in the United States. We're over 500,000 now. So you can see how it compares to the Spanish flu and to several different wars. Interestingly, they talk about how it's really not comparable to compare an epidemic to a war, because it's very difficult to take a snapshot in time and determine how many people actually died as a result of a war. But this is just kind of a general overview. I think it's also very interesting to look at COVID-19 as compared to deaths that we see from chronic diseases like heart disease, cancer. If you look at this data is actually from a snapshot in time. So this is a little bit more relevant to be able to compare it now. So this is data taken during a 4-month period from 2020. And so if you look at COVID-19 during that 4-month period, there were 103,000 deaths due to COVID-19. If you look at the same average of deaths from a period from 2014 to 2018 for all of these other causes of death, so they looked at the same 4-month period of time, then you can see how many people died of those things during that time. So it is somewhat less than heart disease and cancer, but still comparable in getting towards the number of deaths that we see from that. I also like to talk a little bit about how COVID-19 compares to the viral hemorrhagic fevers like Ebola, Marburg, just because I hear a lot of people try to compare what the different epidemics or pandemics have looked like. And so, as you know, we have seen a much broader spread of COVID-19 than what we've ever seen from Ebola or any of the other viral hemorrhagic fevers. There are a couple of different reasons for this. One of them being the fatality rate. So if a virus does not have a host, to transmit it, then it is not a very good pandemic disease. So if the virus kills the host, which in Marburg and Ebola, they have a very high fatality rate of 80%, 40%, then if that person dies, they do not have the ability to walk around and spread the disease. Now we see a little bit more spread with Ebola because in Africa, some of the practices with the deceased involve contact with that deceased body. So you do see a little bit of transmission due to that. However, you don't see the full pandemic spread like we've seen for COVID-19, just because the human is not a great host for it because it is such a devastating disease. And also with COVID-19, we have asymptomatic transmission. So a human can have no symptoms at all and have the disease and be transmitting it unknowingly. And that is a very good way to transmit disease. So if you don't know that you're sick and you're going out and you're spreading it, then you're going to have a much larger number of people affected by you. And this is where we are currently within the United States. So the lighter colors are lower numbers of cases. As you can see in the Northeast, we're seeing much higher levels of transmission and than we are in the lower states. And I'll talk a little bit more about that here in a little bit about why that may be. But I think it's also important to look at what we've seen in case numbers over the last year and in the time of the pandemic. So this graph here with the green and blue lines on it, if you look at the green line, these are the number of confirmed cases since January of last year. So you can see we had a pretty gradual rise coming up to about Thanksgiving of last year, where we saw some pretty dramatic spikes. I think those spikes that you see there are likely the result of Thanksgiving and Christmas. We definitely saw more people in the hospital and more people nationwide who were infected after those times, because I think we let our guard down and did a little bit less social distancing. But what's really concerning to epidemiologists and hospital systems and hopefully you is this little tail that you see where after March, the rise in cases is going up pretty exponentially. And so we are definitely concerned that we are heading towards another spike in cases, and the data seems to be showing that is what's happening. So you can also see here the average daily new cases over the last 14 days. You can see where the hotspots are. The darker red is bad, green is good. So United States is sort of in the middle towards bad, that we are seeing a decent number of cases that are coming through over the last 14 days. And this is just another depiction throughout the United States of where the increase here towards March is coming up. If you look at the red line, that's the average over the last 7 days, and we are seeing that go up. Interestingly, this graph right here, if you look at the red line, this is the daily trends in deaths. So while we are seeing an increase in the number of cases that we're seeing, we are still seeing a decrease in the number of deaths that are occurring within the United States due to COVID-19. So my guess is that that is in large part due to the vaccination efforts, and especially that the vaccination efforts started in the older population, because that is where we are seeing the majority of deaths, and we'll talk about that a little bit more. More graphs. So this is what I find to be a very important story through COVID-19. And this is really, to me, one of the best depictions of this story. And that is the disparity that is within different races of who is getting COVID-19 and who is dying from COVID-19. So if you look at the gray bar on the bar that has or on the graph that has the red bars, the gray bar is the percentage of the US population and that these ethnic groups, what each ethnic group has as far as the percentage of the US population that they are. So the Hispanic population, you can see here, the gray bar is just below 20%. However, for the red bar, that is the percentage of cases in the Hispanic population. And there is a huge disparity there that they are 29.7% of the cases. And similarly, in the American Indian population, you can see they are a much larger proportion of the number of cases. Whereas in the white non-Hispanic population, you can see that the number of cases within the white population is much lower than the actual percentage of the population that is white. So throughout this pandemic, we have seen a disparity in African American, and that's not shown as well on this graph, but African American and Hispanic and American Indian populations that are getting this disease at a larger proportion than what they are of the population. And then you can see on this graph with the deaths on the blue graph, is similarly shown that the Hispanic and African American are dying at a larger proportion within their race than the white Caucasian population. So it really shows us what disparities that we have in access to healthcare. I think there are several things that we think could be related to this. One of which is that, and we saw this early in the pandemic and continue to see it, that the Hispanic population has a larger tendency to live in a congregate living setting. So they may have a house that has a multi-generational family living in it. So they'll have from the great-grandmother down to the great-grandchildren all living in the same house in one family. And then those children that are going out to work, or anyone in the family that's going out to work is coming home and having close contact with more people at home than they would otherwise. And we are seeing a larger number of cases based on that. And then access to healthcare. So that's when you see deaths due to the disease, accessing healthcare later, or not having access to healthcare at all. That is what is causing the disparity within those populations. And then you can see cases by age group. The case numbers tend to be right around in the middle of the age groups. And you can see the disparity if you look at deaths in certain age groups, that the deaths are more concentrated in the over 65. And you can also see that huge gap between the end of the gray to the end of the blue. And that is the number over what you would see in the normal population. So that is a huge gap, and definitely what we are seeing, that we are having more deaths in the over 65 population. And another really tragic thing about this virus and this pandemic in the last year is that for the first time in a really long time, we have seen a significant decline in life expectancy for 2020. You can see on here that in the Hispanic population, their life expectancy decreased by 1.9 years. In the white population, 0.8 years, and in the Black population, 2.7 years. So that is a pretty big, it may seem like a small number, but it's a pretty big decrease, and it's quite a bit more than what we've seen in the past. And this is just a little bit more information about what we've seen in the excess deaths and what we've seen in the different races, that it is disproportionately affecting the Black and Hispanic populations. And again, so more graphs to show the same. This is the CDC's depiction of excess deaths. So everywhere that has a little cross, a little red cross over it, is a week that had excess deaths. So you can see starting around, it looks like this is March, that the United States started seeing excess deaths, and you can see where that is over what we would normally have seen in the orange average line. And this is by state. I always like to bring it home a little bit. So this is what we've seen by state. If you look towards the end of this, North Carolina is shown here. So these are total deaths by state and percent of deaths due to COVID-19 in the 75 and over age group. So the green is the total deaths, and then the red indicates, and this is on the top graph, indicates the total deaths due to COVID-19. So you can see that North Carolina is towards the end of the pack in the total deaths in the over 75 population, with 7% being due to COVID-19. And then this is just by state. So I will leave these in here for you to look at, and I'll make sure that these slides get out to everyone. So the Buncombe County data is really showing pretty much what we're seeing throughout the United States, which is that the cases are seeing a little bit of an uptick. Deaths are also seeing a little bit of an uptake, which is a little bit different than what we've seen throughout the United States in the CDC graph I showed earlier. The percent positivity stays about the same as what we're seeing. We've seen a little bit of an increase, but not too terribly significant. Testing volume remains about the same. New hospitalizations remain about the same. Percent of beds used for COVID is on the downward trend, and percent of ICU beds has been going down and seen a little uptick in more recent times. So I will tell you from the Mission Health or North Carolina Division of HCA standpoint, what we're seeing here in our hospitals is really reflective of what they're seeing nationwide. Around Thanksgiving and Christmas, we saw a pretty significant increase. So we saw that same real increase in numbers. And then lately the numbers have been quite low. And what is concerning is that they do seem like they might be trickling upward. I keep being hopeful that we'll be protected by the mountains and maybe immune, so to speak, to the increases that we're seeing in the rest of the US and the world. But I fear that that may not be the case. We may see another uptick coming soon. And I will stop for questions here in a minute, I promise. Can give you a little bit more data with a few more graphs. And I found this just the other day, and I find it so fascinating. And it took me a while to actually figure out what in the world I was looking at, but I thought that everyone might find this as interesting as I did. This is the Pandemic Vulnerability Index, and this is something that is on the CDC COVID site. So what this looks at is 12 different factors that make up this funny looking little fan here. And the closer you get to 1 for each of these, the worse it is. So you want a lower number is better for each of these. So the smaller your little pie piece is here, the better. And they are looking at many different factors within Buncombe County to determine all of these things. But so the red is infection rate. So the number of transmissible cases that we're seeing is a 0.5. Infection rate, disease spread, so how many people are infecting other people, let me see, is a 0.1. So that's actually the tiniest one that we have here. So the transmission is low. The population concentration, so this just looks at how concentrated is everyone living within Asheville. That is a 0.68. This is looking at many things, such as how our traffic patterns are, where the housing is. I mean, there's quite a bit that goes into looking at these to determine how vulnerable we are for spreading COVID to one another. Social distancing, so this also looks at mobility. So how much are people getting out, going to bars, doing things that we weren't doing during the highest points of lockdown. So we're at a 1 for that, which means that based on their calculations, we are not doing a great job about social distancing at this time. How much testing are we doing? What are the population demographics? Health, environment, and air pollution is kind of a static figure. So you can just kind of look at this and see that we are not doing horribly in a lot of things, but here in Buncombe County, we probably have a little bit of room to improve. And then I just went ahead and pulled some of the local counties, and you can look at this at your leisure. I pulled Macon County, Mecklenburg County, where Charlotte is, Henderson County, McDowell, Haywood, and then put Buncombe in here to compare against. So you can just see how we're doing throughout Western North Carolina in comparison to some other areas. I'm gonna actually pause here for a second to see, Karen, if we have any questions I can answer.
Yes, you have 4 questions.
Okay.
So, and then I'm going to ask you at the end of the questions about the poll, if you would like to start the poll.
Sure.
Okay. So the 4 questions are, do you want me to read these individually or read them all to you, all 4 of them at one time?
Individually would probably be better for my little brain.
Okay, good. First one is, do all states report the relevant numbers to the CDC correctly?
That is an excellent question, and one that I actually get asked fairly frequently. Hospitals and any testing location is required to report all positive cases of COVID and all negative cases of COVID. And many of those actually come through direct feeds from laboratories. So my answer is probably. I will say that most probably everyone is reporting correctly. I do know that if a county health department feels that you are not reporting correctly, they will be on you to do so pretty stringently. So everyone is doing their best effort, and those typically come out of a department like mine. If it's a hospital, we do all of the COVID reporting, and we do our very best. We find out all of the positive cases and send those to the health department every day. And so that should be happening with some regularity, yes.
Okay, that was from Linda McDonald. Thank you. Now, Bill O'Connell's got 2 questions. Can you offer us an estimate of the imputed number of dead due to the effect of COVID infection versus the 550,000 deaths based on only death certificate data? What is the estimated number of added deaths experienced in the U.S. due to COVID infection? That's his first question.
I think that is an excellent question that I'm not sure anyone is able to really know. Similar to how we report COVID cases, my department reports COVID deaths. So if we have a patient who has COVID and expires, that information goes to the health department with all of the inpatient information, death summary, etc. And the health department is able to determine from that if the patient died from COVID or if the patient had COVID, recovered, and consequently died of cancer or some other reason. So, they are able to make a tally based on what we send them if they think that the death was immediately related to COVID. Now, if the death happens outside of a hospital or outside of a situation where they are able to get all of that information, then it may be a little more difficult to know what the actual cause of death was. But I think everyone is doing their best to make sure that that data is as accurate as humanly possible.
Thank you. And Bill's got one more question, and Linda's got a question. Given the disparity of COVID infections among various race ethnic groups and in Western North Carolina, what actions is HCA Mission Health undertaking to offset this through its acute care setting, as well as what it might be doing to contribute to public health efforts in WNC?
That's a great question, and I appreciate you offering the opportunity to talk about that a little bit. So we have quite a bit of outreach within HCA Mission. We are really trying to focus our vaccine efforts into some communities with disparities as much as possible, reaching out to different communities who may be able to help us get the vaccine out there and get people vaccinated who may not otherwise be able to do so, as well as our medical director has much contact with community leaders and health department leaders and other heads of hospital systems to look at this very thing and try to figure out what we can do to be more effective in those areas. It's a constant effort and something that we take very seriously here.
Thank you. And last question from Linda McDonald. Should people who have had both shots and past 2 weeks still get tested before they travel?
Well, I think that is really dependent on what the requirement is for whoever it is you're traveling with or wherever it is you're going. I don't personally know at this time what different airlines or countries where you may travel are requiring. In my opinion, a COVID test is always a valuable piece of data. Having had the vaccine is not going to cause you to test positive. So, being able to have that test and know, I think doesn't hurt anything. I know it can be extremely inconvenient. But I think it just depends on what's being required for where you're going and who you're traveling with.
Thank you, Jacie. Now, would you like to tell your participants about the 2 or 3 polling opportunities they're going to have?
Absolutely. So we have an opportunity to have a little bit of participation. Doing classes like this on Zoom makes it a little bit harder for me to talk to you guys and have you all participate in the presentation. So we are going to have a couple of poll questions, and we're going to start with the first one that is whether or not you have had COVID-19. So have you been ill from COVID-19? And if you will go ahead and answer that, we will tally the responses and let you know what they are. So should I go ahead, Karen, and go on while we're waiting on those? Or
I think so. I think so. Yeah.
Okay, and then we'll have a few more opportunities as the presentation goes on. A big question right now is, what are the variants that are circulating, and what should we think about them? What should we do about them? What does this all mean? So I'm going to talk a little bit about that. And with that, I'm going to get here we go. Well, that's great. So have you been sick with COVID-19? We have 3% who say yes, and that is 1 participant. 35 participants and 95% say no, and 1, which is 3% again, say possibly. All right, so most of us have not had COVID-19. Very good. Thank you. All right, so the variants. We have 3 variants right now that we are focused on, and I'm going to talk a little bit about what that really means. So you see this red blob right here on the slide. This is the spike protein that creates that crown on the coronavirus that I talked about earlier. So these little yellow pieces in here are the mutations to that spike protein that are causing these variants. What that spike protein does is it enables the coronavirus cell to attach to the human cell to be able to deposit its badness into the human cell. So these variants do several things. They can kind of uncurl the spikes on the crown so that they're able to connect better. But the most important thing that they do is they make it difficult for the body to recognize that they've seen it before. And so anything that is a variation within the virus is going to make it difficult for your body to recognize it. So say you've had COVID-19 and then you're infected with the variant, your body may not mount the same immune response it would if it was exposed to the same variant of COVID-19. So the 3 that we're seeing right now are the UK variant, the South African variant. No, why are my slides? There we go. And the Brazil variant. They're seeming to spread more easily and more quickly. And so there is concern that we may have increased cases because of these variants. And that may be what we're seeing in our little spike throughout the world of cases right now. However, at this time, the studies are suggesting that the antibodies that our bodies make from the vaccine will recognize the variants. There are many more studies that are going on to make sure this is true. But at this time, they are thinking that that is going to be the case. So what we don't know right now is how widely have they spread. When you're tested for COVID-19, most people are not tested for a variant. So the test is not necessarily being sent to the state lab or to the CDC to find out what strain of the virus it is. We're not really sure how much the symptoms or the severity will differ. And then how they're going to affect the medications that we have, the tests that we have, and being able to recognize that someone has COVID-19, and then how the vaccines are going to react. Again, initial studies are thinking that it should be okay, but more studies are needed. So this is what we've seen here in the US as far as transmission of the variants of concern. You can see that North Carolina is still in one of the lighter colors, so that's good. The darker, and pretty much everything I'm showing you, darker is worse. So we are still at a point where we're not seeing a whole lot of transmission. We've had 178 cases of the UK variant, no cases of the Brazil variant at this time, and 29 cases of the South Africa variant in North Carolina. I will say that we do know, and at my last check, I think there had been 3 cases of the UK variant in Buncombe County. That number has probably changed. That data is a little bit old, but we have seen some here in Buncombe County. All right, so I think that we have established that coronavirus is here, and what does that mean? So we've been here before, and this is really interesting to me that when you look back to the Spanish flu in 1918, and you look at the headlines, they could absolutely be the headlines that we're seeing today. Flu epidemic closes schools, churches, theaters. What do you do to prevent flu? Don't take anyone's breath. Avoid those that cough and sneeze. Don't visit poorly ventilated places. Don't use common drinking cups, towels, etc. Cover your mouth when you cough and sneeze. So stay home if you have a cold. I think that is really important. Stay home if you're sick. So a lot of the interventions that we had back then are the same interventions that we're using today. There's really not a whole lot new along those lines. And I really like this comic. Those who don't study history are doomed to repeat it, yet those who do study history are doomed to stand by helplessly while everyone else repeats it. And really, truly, it's what we're seeing now in people who don't believe in masks or don't believe in the virus and social distancing, and are not willing to take those measures to make sure that we're not spreading the disease. So you all know, what should we do? Wear a mask, be 6 feet away from people, wash your hands. And why that is, I find this graphic, well, both of these graphics, the one showing the man sneezing and with the photo, and then this one with the drawing. So this is where our 3 feet and 6 feet come from. So your exhalation droplets can go up to 1.5 meters, coughing greater than 2 meters. And then if you sneeze, that can truly aerosolize greater than 6 meters. So I think that just depending on your droplet size that you see in these, they can travel different distances. And so this is why social distancing is so important and why masks are so important. So you want to wear a mask to protect yourself. Yes, it most certainly will protect you from the majority of the droplets that you may come in contact with. It is possible for some to get through. As we all know, masks are not 100% effective, but it also greatly protects others by keeping your droplets inside. So it's very important to wear a mask, not just to protect yourself, but also to protect others around you. And this graphic is just showing in the countries who adopted early mask mandates, their rates of spread were much decreased from those who did not adopt the early mask mandates. And you can see these are Asian countries where it is more traditionally accepted to wear a mask in public. This is something that they just already did. So for them to adopt a mask mandate was not really outside of their norm of everyday life. I really love this study, and I want to make sure that people hear about it and know the specifics of it. Duke did a study on the different kind of masks that we see and really what their level of protection is, which one works best for A, keeping things in, and B, keeping things out from coming out. Sorry, keeping things from coming in and keeping things from coming out. And interestingly, this graphic is a little funny because the 1, 2, 3 on the pictures doesn't match the 1, 2, 3 on the side here. So the 1, 2, 3 on the side is ranking them from most protective to least protective. So you can see that number 14 in the photo, which is a fitted N95, is the most protective. And I think everyone is pretty aware of that at this point, that is really your ideal mask that you want to have if you're going to be in a risky situation where there's aerosolizing droplets or you are coming in contact with a known COVID case. Now, the reason that I bring this up is that down here at the bottom are, I think, some really important factors, which is a double layer bandana, not super protective either way for keeping things from coming out or keeping things from coming in. And the gator style neck cover that you can use as a mask, this to me was the most interesting piece of data from this study. So this gator that we see people wearing all the time actually increases droplet output. So what it does, because it is spread and stretched so tight across the mouth, it is breaking up the droplets, letting them out and making them smaller so they can travel further. So they actually saw an increase in transmission from not having a mask on at all. So if you see someone in a gator, my recommendation is back away slowly, and please don't wear one yourself, because they are not good protection for others if you have COVID. So the other thing that I like to tell people are the masks that have the valve on the front. Those are great at protecting the wearer, but those valves don't filter the droplets that are coming out. They only filter, it's a one-way valve that filters coming in. So those valves are not good to protect someone that you're coming in contact with. So if you have COVID and you have on a mask that has on a valve, the droplets coming out are not filtered. So I also recommend not wearing those. And if you see someone in the grocery store that has one of those on, I would just go to the next aisle and come back to that aisle later. And then social distancing is a really important part of how we decrease the spread. So this is a great graphic that shows how one person can infect a number of people. So if you have one person with COVID and they do 0 social distancing, they will on average by day 5 have infected 2.5 people. Then those people in turn by day 30 will have infected 406 people. If you reduce your social exposure by 50%, on day 5, that one person with COVID will only have infected 1.25 people. And those people by day 30 will only have infected 15 people. That's by decreasing your social exposure 50%. Now, if you decrease your social exposure by 75%, on day 5, that person will have only infected 0.625 of a person. And then by day 30, those people will only have infected 2.5 people. And so this is why social distancing measures are put in place and why they work and why it doesn't work when people don't follow them. I like this graphic just because it shows back in June when we did some really great social distancing and some really great closing of different types of businesses, that we saw a pretty steady low rate of cases. Then when all of that reopened in Florida and Texas, you see the large spike that happened. Now, I will say I fully understand the plight of small businesses and just businesses in general throughout this pandemic, and that has been absolutely devastating. So it is very difficult, and I really feel for the governments that are trying to put the right things in place and keep everyone alive and able to feed their families. And, you just kind of have to take it all into account and weigh it. That being said, one thing that is not hard on businesses is mask mandates. So I do take a moment here to talk about what was very surprising to me on March 4th when I pulled this graphic, that there are so many states who actually have no mask mandate in place. And this came to light to me. My home state is Texas. So when Texas revoked their mask mandate, I was completely shocked and disappointed. And then I pulled this and thought, wow, I had absolutely no idea that all of these states did not have mask mandates. And so I did a similar talk a few weeks ago, And I showed this graphic, which is now very out of date, and I will show you why in a minute. But I found it really interesting that there seemed to be some correlation with the blue and green here. This is the number of cases, so the daily case rates in these states, and darker is worse, so darker means more cases, versus the states with no mask mandate. And I thought that seemed an interesting correlation in a lot of states that don't have mask mandates, where you saw a higher number of cases. Now, before I gave you this talk today, I went to pull the more recent graph or state map, or sorry, United States map, and this is what we see. So in fact, today, you can see that the correlation is kind of gone. And in the Northeast, where we do have some mask mandates, you're seeing more cases. And in a lot of these states down here that did not have mask mandates, our cases seem to be decreasing. So my theory was blown out of the water, and I just had to admit that to lots of people. So I put that in here today. So then I started thinking, well, maybe the number of vaccine doses would correlate to the number of cases in a state. So maybe if you were in a state that had more vaccine doses that were administered, then you would have fewer cases. That seems like it would be logical, but really it doesn't prove out in the data either, because in this darker blue graph here, these are the total vaccine doses. Darker is more doses administered, lighter is fewer. Then you look on the case rate in each state, and it doesn't seem to correlate. So all that to say that I think more data to come, that we will probably see more of a correlation later. But I think as we're blanketing with vaccine, hopefully everyone will be to a point where we're all the light green color. Okay, I'm going to pause here for our next poll question. Can we have the next poll question pulled up? All right, so this is a two-part question. So have you had the COVID vaccine? And if you have not had it, do you plan to get it? So if you all want to go ahead and vote on your poll, and I'll just wait a minute to have the results before we move on with the slides.
Jacie, you want me to give you some questions?
That'd be awesome.
All right. So you have about three additional questions. And the first one's from Linda. What human differences cause people who are statistically the same age, health conditions, and with similar access to healthcare have such wildly different reactions to the viruses, from asymptomatic to dying?
Well, that's a really good question. And I think that it is one that we're still studying. And I think I have my own theories. So these are the theory of Jacie, and not necessarily based in science, but I think that it's based in some science. It's based in the science that I know. And that is that, we see coronaviruses as the common cold. And there are lots of different strains of coronaviruses. And I think there is some possibility that the people who are asymptomatic or have very mild symptoms may have been infected at some point in their lives with a common cold version of coronavirus that may be similar enough that your body mounts some immune response to it. So I think that's one thing, that perhaps your body has seen something similar enough that it knew to say, I'm going to do something about this and bring down the level of virus in this body because this seems familiar to me. My other theory is that, and I think this is more than just theory, this is actual science, that every human has a different level of immunity that their body is able to provide to any given illness. And so, you see immune booster formulas out there and, things that people say can boost your immunity. I think that immune boosting things may help out, but also things that decrease your immune response, like stress and previous illness and chemotherapy and steroids that you may be on. So all of those kinds of things can decrease what your body can do when it sees a virus. So I think some of those things also factor in. And, you know, really genetics. Everyone has a different genetic makeup that either makes them have stronger immunity, not as strong immunity. So all of those things factored together are likely what makes such a range of symptomology that we're seeing in people.
Okay, thank you. Now, you've got two other questions. Why was the 3-meter N95 mask crossed off in the photo of as being ineffective? And mask, she had another question about mask. Okay, so I'll just, oh, it's an ineffective mask, perhaps that's why was the 3-meter N95, yeah.
So that is the one that has the valve on the front. And so that's the valve that I was talking about that will let things come out. So it is not ineffective to the wearer, but it is ineffective to anyone standing in front of the wearer who may be exposed to their droplets, because that is a one-way valve and it is not filtering what comes out. It's only filtering what goes in.
Okay.
Was there one more, Karen?
There were about 3 or 4 more questions.
Okay. Maybe we'll hold off on those and do them at the next pause.
Okay, sure.
So let's talk about these poll results. This is great. Have you had the COVID vaccine? So 94% have had it. That is absolutely excellent. 94% who responded. And only one person has not. Then if you have not, do you plan to get it? It looks like yes. And then we have one saying, I'm still unsure. If that one person who's still unsure wants to call me, you are welcome to. My phone number is 828-213-5464. And I will certainly talk to you about that if you would like. All right. Thank you all for responding to the poll. Okay. This is the different phases graphed out on who is able to get the COVID vaccine. I'm sure we've all seen this. We're at a point now where they're about to open up in North Carolina so that everyone can get it, which is very exciting. And just had to say that I have sung this song since the COVID vaccine came out because I am not throwing away my shot. I did get my vaccine and was very excited to get it. And I want to talk a little bit about what the vaccine is, what it means, what it does. So vaccines are when they take it can either be a full virus that is weakened or dead or a piece of a virus, and then they put it in you and it makes your immune response ramp up and develop antibodies so that it will remember that in the future. And then if that virus gets in you later, then your antibodies will fight it off. And there are different types of vaccines. When they take a small piece of the genetic material, when they take a protein like the spike protein that is on the coronavirus, or they can take a whole virus like I talked about and it can be dead, inactivated, weakened, or a viral vector virus. So the coronavirus vaccine is actually, so if we're talking about the Pfizer and Moderna vaccine, those are RNA viruses. So what they have done is, this is a spike protein again that I showed you before. So they have taken a piece of the spike protein and made it to where it can be injected in you and your body can recognize that. Now, it is not the whole virus. So this spike protein in and of itself cannot cause coronavirus. So I think it's really important for people to know that having a piece of the virus inside you will not cause you to have COVID-19. So just a little part of it is not the whole virus, and it can't make disease. The Johnson & Johnson vaccine, which is a one-dose vaccine, is called an adenovector vaccine. So adenovirus is a common virus that causes illness, and there are some adenoviruses that don't cause illness in humans, and they've taken one of those that doesn't cause illness in humans, and they have put a piece of the coronavirus into that adenovirus vector, so that adenovirus is able to go inside the human and replicate and do the same thing that the RNA vaccine will do, and make the body recognize that piece of the coronavirus. But again, it is not putting in a whole piece of, or a whole virus of coronavirus, so it will not cause disease. As you know, the vaccine development has been sped up greatly. These are the different phases that we go through to develop a vaccine. So it goes through 3 phases of clinical trials, and this typically takes many, many years to come to a final product that can be distributed as a vaccine. Phase 1 is typically tested on 20 to 100 test subjects. It's the smaller test subjects, just to ensure that there's safety and efficacy, and this could take several months. Then phase 2 would be several hundred people, take up to 2 years. Phase 3 would be 30,000 people, up to 4 years. And we've squunched that all into a warp speed time frame. So whereas we might have normally had vaccine by November of 2033, we have had vaccine much quicker than if we had gone through the normal timeframes. So normally it would take up to 73 months to completion. At warp speed, it's been much faster. And this is, did I skip one? No, I just have them backwards. This is the number of vaccines that have gone out in the United States. So there has been 200 million vaccine doses delivered. 153 million of those have actually been administered. That is 30% of the population has had at least one dose. 16.9% has had 2 doses. It's a little bit different if you're looking at the only those who qualify for the vaccine, because the vaccine is not yet approved for children. So it bumps it up to 38.4 have had at least 1 dose, and 21.7 have had at least 2 doses. And then in Buncombe County, the percent of the population is 19.2%, which if you're only looking at those eligible for the vaccine would be 23.4% are fully vaccinated. So we're doing a good job here in Buncombe County of getting the vaccine out. We just need to keep it going. And I did just realize that there was one thing I wanted to talk about on this slide that I skipped over a little bit, and that's the AstraZeneca vaccine. There's been a lot of controversy surrounding the AstraZeneca vaccine for a couple of reasons. It is not yet here for use in the United States, and I saw some information yesterday that Joe Biden may not, it says that the United States may not need it, and so we may actually not end up having that here. But there have been a few instances of people who have had blood clots after having the vaccine. There are still studies ongoing on that vaccine to determine if that was due to the vaccine or if those were people that just would have had that normally. And then there was some controversy surrounding them maybe inflating their numbers on efficacy. But I think that in the end, it's looking like the AstraZeneca vaccine will be in the upper 60% efficacy range. And so, I think that the common message here is that regardless of any ranges of efficacy of these vaccines, you should get the one that's available to you. If there is a vaccine that is available and you are able to get it, you should get that one. And that all of these vaccines have been found to be 100% effective at preventing death, while what the numbers here are showing with the 95%, 94.5%, 72% is their efficacy in preventing severe disease. So I think that they're doing a great job preventing severe disease. There could still be some possibility that you would get a mild case, but very unlikely, if not completely unlikely, that you would die from COVID-19 once you are fully immunized with the vaccine. So, okay, now that we talked about that, I think this is one of the greatest success stories in this whole pandemic is the rollout of the vaccine to nursing homes in the very early phases of vaccine rollout. You can see here in the red line, deaths among nursing home residents once the vaccine started rolling out to them just went way, way down. And that was a really tragic scenario when COVID-19 got into a nursing home, because it was virtually impossible for them to do the appropriate social distancing, and it just spread like wildfire within nursing homes once it got there. So great success story that they rolled it out to nursing homes, and there has been a huge decrease in the nursing home deaths due to COVID since then. And as we discussed earlier with the inequities in among the different races with the disease, this shows the inequities in vaccination. The blue is the percent of the population that is within that ethnicity. And so you can compare the yellow, which is the percent of people vaccinated, to the blue. So as you can see in the African American population, they make up 21% of the population, but only 15% of those vaccinated. In the Caucasian population, Caucasians make up 63%, but 77% of the vaccinated population. So I think it's just important to keep that in mind, and for public health and health systems to continue to focus on these disparities and inequities. So I think we all remember back when this hit and we thought, oh, definitely this will be over by the fall. Schools are definitely going to be open in the fall. There's no way this is going to keep going. And it has. And so one of the questions that I am asked frequently is when the US will reach herd immunity. And this is one of the last things I want to talk about. And I put this in here because if you type into Google, when will the US, the first thing that comes up is reach herd immunity. So this is the world map of vaccinations. As in most of my maps, darker is better. So you can see the United States is upwards of 23% of the population covered. Here's North Carolina. And this is our best estimate this time. So this comes from Bloomberg, and they have a really amazing COVID vaccination tracker. If you ever get interested in going in and looking at crazy amounts of data like I do. So in the United States, we're at almost 3 million vaccines being given a day. And so the general consensus is that around 75 to 80% of the population will need to be fully vaccinated to reach herd immunity. So today, the estimation is that it will take us about 4 months, if everyone is on board with being vaccinated, to reach herd immunity. So 4 months, that puts us around August, September time. So we just need to keep moving. I'm going to go through this pretty quickly because I want to leave time for questions. There was a point in time when we thought that when flu season hit, that it was going to be a humongous disaster because we would have flu and COVID circulating at the same time. They have very similar symptoms, except for loss of taste and smell. But what we've actually seen are relatively low incidences of influenza this year. So this is our United States map, and we're still green across the United States, which means that we really have very little influenza-like illness activity. So this graph gets yellow, orange, red as influenza activity continues, and the whole United States is still green. These are the numbers of flu that the CDC is seeing from clinical laboratories, still in the 50s to 100s, which is so incredibly low per week. And I find this to be one of the most interesting graphs. So in the yellow here at the very bottom, you can see the number of influenza deaths. And you can see here for 2020, around week 50, which is around where it normally starts, there's nothing. So we're just not seeing influenza deaths. Now, the blue are the number of COVID-19 deaths. So you can see that that is definitely happening, but influenza deaths just aren't. And we are testing for flu. We're just not seeing people who have flu. And so what we're thinking that means is that all of these interventions that we're doing, the social distancing, the masking, is keeping flu from being transmitted as it normally would be. And I will give you these slides again, just so that you have them and you can look at these things later. I want to make sure that we have a minute to answer questions. So this is a list of who's at increased risk. They also have a list of maybe increased risk, but we're not entirely sure. A list of things that people are really wondering, should I do these things? And what my answer to that is what are your personal risks? What are the risks within your family? How devastating is it going to be to you and your family if you are infected with COVID-19? So, you know, it's on a spectrum. If it's very devastating to your family to get it, you know, you have someone at high risk that lives at home with you and they might die if they get it, then I would do way more and be way more careful and stay home and not go out to restaurants. If you feel like you can go out to a restaurant and wear a mask and you're a little bit less on that spectrum of risk, then, you know, we're opened up a little bit to that point where you can do it. But you have to think about, is that the right thing for you? I don't think you need to put your cat in a mask, and I don't think your cat would like it very much. Should you keep your kids home from school, or should your family members keep their kids home from school? I think that it, again, depends on the level of risk within your family. And then the CDC has a lot of really good resources about whether or not your symptoms could be indicative of COVID-19. So there are a lot of diseases that mimic some of the symptoms, to include seasonal allergies. And I think the biggest question I get from people is, well, what I'm feeling right now feels like seasonal allergies, but could it be COVID-19? And so this can help guide you a little bit in what's common for the disease and what's not. And so I end with saying that what's really important in your life is to determine where you are on that spectrum of risk and what your life can withstand as far as mitigating those risks. So if it means that I can't go to work and I can't provide for my family, and my family is going to starve because I can't put food on the table, then I think you go to work, you know, and that is taking one step more in the risk category. You're leaving your house, you're doing things, but you have to think about it in, you know, what do I need to do for my family? If having social time with your family members is extremely important to you, and it could put you into depression if you don't have that, you know, the CDC has opened up the guidance some, especially if you're vaccinated. So, you know, maybe it is important that you go see your family. And, you know, you really have to think about it. Is avoiding all risk more risky? And, you know, that coming from an epidemiologist, I think we always have to think about what is the highest risk thing. Is it not going to work and not being able to feed my family, or is it contracting COVID and, you know, having the repercussions of that? I also want to state, and if you remember anything from my talk today, please remember that one of the biggest ways you can prevent from having COVID-19 is to keep your fingers out of your face holes. All of the mucous membranes on our faces, we're constantly licking our fingers, rubbing our eyes, rubbing our noses, and that's a great way to get viruses into your system. And so, one of the things that we see in a hospital, people licking their thumb to turn a page, and we're in a hospital. Let's let's keep our fingers out of our mouth. So please just remember, keep your fingers out of your face holes. And that is all.
Hi, Jacie, you have 22 questions.
Oh my goodness.
All
In
right,
7 minutes. Okay.
And 7. All right. So looks like, okay. Probably, okay. This is going to be from Kathy Templar. Unable to submit second poll. Second question does not apply to me. Okay. I did get the shots, but I could not submit. Okay. This is from Jan. If we already have had the vaccine, how do you want us to answer the second question, which is worded for those who have not had the vaccine, but we can't submit or respond without answering the second question. So, okay, what will it take for USA to meet President Biden's goal of small group gatherings by 7/4/21?
By 7/4/21. I have not seen that goal. I would think that getting as many people vaccinated as possible is going to be the key. If it were me and I was going to a small group gathering and I didn't know that everyone was vaccinated, I would still wear a mask. And I might even request people who are not vaccinated at that small group gathering to wear a mask as well. Again, I think it is all about your own personal willingness to put yourself at risk. So, you have to think about that on your own. But I apologize. I'm not sure what President Biden's goal is. I apologize for that.
And I'm just going to ask you to say your phone number again, Jacie, and also about when you'll give us your slides, but we'll ask Jacqueline to respond to that. So will you give your phone number first so it can get in the chat? Then I'm going to finish answering your questions. Would you repeat that?
Yes, it is 828-213-5464.
5464. Okay, thanks. Now, Jan says, I appreciate Warp Speed for approving COVID vaccines. My impression is that Warp Speed was the standard process for any vaccine for a pandemic, as opposed to the timing required for a standard pharmaceutical drug. Is that correct?
That is correct.
Okay. This is from Cindy. How can a vaccine be 100% effective in an unhealthy person, i.e. obesity, diabetes, and cancer?
So that's a really great question. And the studies have shown that the subjects who received the vaccine, there were no deaths due to COVID in those subjects. I am not privy to whether or not they had someone with such severe comorbidities with the disease within the study who were vaccinated. But that certainly may be a factor. I know that is the population in which we are seeing the highest number of deaths. So that's a fantastic question. And I think I would need to look a little more into the studies and how sick the people were with comorbidities that were included in those studies. My guess is that that would be a later phase.
Okay, thank you. This is from Bill O'Connell. Ray, the slide about vaccine distribution inequities, why did you not include a split out for Latinos, or were their data in the other, or were they combined?
That's a really good question. And as I was looking at that slide, I was wondering the same thing. So I will have to look back at that and see where so here's what I think the answer to that is. And I'm 99% sure this is the answer. So I'm going to go ahead and tell you. Whenever you look at race, it looks at what you saw in that slide. And then a subset of that, all of those people can answer, are you Hispanic or Latino? So that is typically a subset of those. I know that it wasn't in the previous slides, but I think that how that data was collected, Hispanic was a subset of those groups. And I can certainly confirm that and follow back up if needed.
Thank you, Jacie. This is from Thalia. I am a very allergic person. I was waiting for the Johnson & Johnson vaccine because I thought there would be less risk of allergies. Is that true?
So typically the allergies that you see from vaccines are from the additives that are in it. My understanding was the Pfizer and Moderna had no additives. I am less certain about the Johnson & Johnson. I think the best thing to do is, if you have an allergist, is to consult with them. If you don't have an allergist, consult with your primary care physician. And what they'll do is they can print out a list of everything that's included in the vaccine, and then they can go over what may be at highest risk to you. I know there are a lot of people who are having those conversations with their physicians, and the best thing to do is to just take them a list of every ingredient that's in each vaccine.
Thank you. This is from Stefan Stackhouse. Given the ease and volume of international travel in normal times, does it really make sense to talk about herd immunity for any population less than the total global population?
I think that is a really good point. And we are so mobile, and we are so limited by the other populations that are coming in and where we're going. So I think it's a really good point. I do think that as we reach herd immunity in the United States, somebody coming in from another population would be, and excuse the term here, but kind of a drop in the bucket. So one person coming into the population who already lives here, and so the herd being the United States. So you have one person coming into a herd, the herd has immunity. And then if you take yourself to an area that doesn't have herd immunity, it's the reverse. So, I think that you can look at it any number of ways. I think moving towards the most people vaccinated possible is really our end goal, and that's hopefully where we're headed.
Thank you. When will the J&J vaccine be available, Jacie, do you know?
It is available. It's being given here in Buncombe County. I know it's being given throughout North Carolina. So it's out there and definitely available. It's great for people who have a hard time accessing healthcare. So if it's going to be hard for you to get somewhere twice to get a vaccine for whatever reason, the one dose is actually a really good option.
That's awesome. This is the last question. Wouldn't it help with all underserved Black and brown populations if the news reported that the shots are free? Seems like worth trying. Maybe everyone doesn't know it.
That's an excellent point. I think that, we certainly have not made a point to say that. And I hadn't thought of that. So thank you. I will certainly recommend that here. I think that's a really great point.
Okay, and maybe the last question would be for Jacqueline, our host, is when might the slides be available for OLLI folks to see these wonderful slides of Jacie's?
The slides from a presentation are typically available approximately a week after the presentation on OLLI's website under the presentations page. However, we cannot guarantee a timeline for the availability of a recording.
Okay. All right. So maybe we should just check back periodically. How does that sound, everyone? And Jenny, did you want to make your announcement one more time? Maybe some people didn't get to hear that about the next two Fab Fridays.
Yes. Give me a second.
And
Yes.
Jacie, go ahead.
No, okay. Well, I just jumped in a little sooner than I was supposed to, folks, so I do apologize. I was basically wanted to say how glad we are to be back in touch with you after a break, and that if you there's two ways you can figure out where future Fab Friday presentations are. One is posted on the OLLI website, and the other is we are trying, next Fab Friday will tell you about our next Fab Friday, but so we're trying to announce the not health related Fab Fridays. And next week, their next Fab Friday is a screening race with Marcia Gordon, who's a film studies professor at UNCA. And it's a study, a look at short films, not movies or anything, but things people did on their home cameras and whatnot, with a look to race and identity between the areas, the years of 1950 to 1970s, which certainly covers my childhood and maybe yours. So I think that's a very timely thing to think about. And then we will be back with you on April 16th for the health education series with men's health in urology. We had done a women's health, breast cancer, all those kinds of things about a year ago, and it's taken us a while to find a speaker, but Dr. Terlecki, who is actually the head urologist or head of the Urology Association for North Carolina, has very graciously offered to come and speak on Zoom to us. So hoping that people will be interested in those two talks.
Thank you, Jenny. Thank you, Jacie Volkman. Thank you.
Yes, thank you.
Jacqueline. Thank you. Great. Thank you so much. Wonderful.